Warm regards and greetings to everyone. Myself Leosmita Burhaguhai, a student of 4th professional year of Lakhimpur College of Veterinary Science. So, today I am going to give a presentation on the topic Strangles. So, these are the contents of my presentation. Now, let us start with the introduction. So, the literal meaning of strangles is obstruction of breathing by compressing the throat. So, the name of the disease was given such because this is an acute disease which occurs in equines, which is characterized by catarrhal inflammation of the upper respiratory tract, causing suppuration and abscession in the associated lymph nodes, as a result of which the lymph nodes will enlarge and thus impair breathing. So, the synonyms of this disease are distemper and infectious adenitis. So, now the distribution. The disease was widely prevalent earlier, but now it has receded greatly. It has been recorded in various countries of the world, but it is still unknown in Ireland and Argentina. So, according to a survey performed by Asian Journal of Animal and Veterinary Advances in 2010, out of all the diseases prevalent in equines, more than 8% cases of strangles are reported in India. So now let us come to the etiology. It is caused by the bacteria Streptococcus equi, subspecies equi, which is a gram-positive coccus. This bacteria also form beta hemolytic colonies on sheep blood agar. Susceptible host. This is essentially a disease of equines, and out of the equines, horses suffer more severely comparatively to donkey or mule. So young horses within the age group of 6 to 36 months are the most susceptible ones. So the transmission of this disease can occur through nasal discharge, which is the most important source of disease transmission. It can also occur through ingestion of the contaminated materials, through droplet infection. The stallion may transmit the disease during copulation, and the foal might get the disease during suckling. Carrier animals can also act as a mode of transmission, and fomite transmission is also possible. So the pathogenesis of this disease is quite simple. After the entry of the organism, it localizes in the pharyngeal and nasal mucosa, wherein it causes pharyngitis and rhinitis. Thereafter, the infection goes on to the guttural pouch and it is filled with pus. There is also abscess formation in the adjacent lymph nodes. The infection thereafter spreads to liver, spleen, and joints. So the clinical findings of this disease are: the morbidity of this disease is quite high and it ranges from 30% to 100%, whereas the mortality of this disease is not so much and it ranges from 9 to 10%. The incubation period of this disease is 3 to 14 days, and fever is the first sign of infection and it ranges from 103 to 106 degree Fahrenheit. So within 24 to 48 hours of the initial fever spike, the horse will exhibit signs which are typical to strangles, and they are: it will show mucoid to mucopurulent nasal discharge, and the nasal discharge will be serous at first, and later it will turn to mucopurulent, and then finally it will be purulent in nature. The horse will also show depression and submandibular lymphadenopathy, that is, the lymph nodes below the mandible will be swollen or enlarged. So this is a picture of a horse wherein we can see nasal discharge coming out. Horses with retropharyngeal lymph node involvement have difficulty swallowing. We can also hear inspiratory respiratory noise, which is due to the compression of the dorsal pharyngeal valve, and we can also see extension of head and neck of the horse. Cough is evident in this disease, and that is due to pharyngitis. As I have already mentioned, there will be inflammatory swelling of lymph glands. Later, there will be formation of abscess, which will burst, liberating large quantities of thick yellowish or white creamy pus. So, these two pictures, the one on the left is showing a swollen abscess, and the picture on the right is showing a horse with a burst abscess from where the pus is coming out. So metastatic strangles, also known as bastard strangles, is characterized by abscession in other lymph nodes of the body, particularly the abdominal lymph nodes, and less frequently the thoracic lymph nodes. Streptococcus equi is the most common cause of brain abscess in horses, which is although rare. So the picture below is a picture of a horse brain showing abscess. So the lesions formed in this disease are edema and congestion of nasal mucous membrane, abscess formation in pharyngeal and submandibular lymph node, empyema of the guttural pouch, suppurative mnemonic changes, and the changes in pleura and pericardium. So we can diagnose this disease by asking the history. We can also look for clinical signs. We should check for any swelling of lymph glands, particularly of the submandibular lymph glands. Confirmatory diagnosis can be done by bacterial culture of exudates from abscesses or nasal swab samples. Nowadays, qPCR and ELISA is also performed for confirmatory diagnosis. Complete blood count reveals neutrophilic leukocytosis, which means there will be abnormally high number of neutrophils in the blood. So complicated cases may require endoscopic examination of the upper respiratory tract, including the guttural pouches, ultrasonographic examination of the retropharyngeal area, or radiographic examination of the skull to identify the location and the extent of retropharyngeal abscesses. So we also need to perform differential diagnosis of this disease with glanders. Since strangles and glanders both are a disease that affects the upper respiratory tract of horses, so we need to differentiate it from each other, as few of the clinical signs will be similar in both the disease, like discharge, nasal discharge, and also high rise of temperature, etc. So, as I have already mentioned, strangles is caused by Streptococcus equi subspecies equi, whereas glanders is caused by Actinobacillus melli. So, strangles is an acute disease and glanders is a chronic disease. The nasal mucosa will show inflammatory changes only in case of strangles, whereas the nasal mucosa will show nodules, ulcers, or stellates in case of glanders. The lung lesions are not of tubercle-like in strangles, whereas it will be tubercle-like in glanders. In strangles, no ulcer or nodules are seen on the skin, but in glanders, we will find ulcerative nodules on the skin. In strangles, the pus will show gram-positive streptococci, and in glanders, the pus will show gram-negative pleomorphic rods. So now, let us come to the treatment. So, the clinically ill animal should be provided with warm, dry, and dust-free environment. We can also provide warm compresses on the sides of lymphadenopathy to facilitate maturation of abscess. After the abscess is matured, we should facilitate drainage of it, which will help in speedy recovery. Once ruptured, the abscess should be flushed with dilute 3 to 5% povidone iodine solution for several days until the discharge ceases. We can also use NSAIDs which will help in reducing the pain and fever, and it will also help in improving the appetite in horses with flumitant clinical signs. We can also perform tracheotomy, but antimicrobial therapy is somewhat controversial in this disease because initiation of antibiotic therapy after abscess formation may provide temporary clinical improvement in fever and depression, but it ultimately prolongs the course of disease by delaying maturation of abscesses. So antibiotic therapy is indicated when we find dyspnea, dysphagia, prolonged high fever, and severe lethargy or anorexia in the animal. So administration of antibiotic during the early stage of infection will usually arrest the abscess formation, that is, will delay it. Since the organism is gram positive, so procaine penicillin given at a dose rate of 22,000 IU per kg body weight IML twice daily is the antibiotic of choice. So I have mentioned few brand names of procaine penicillin below. So the disadvantage of early antimicrobial treatment is failure to mount a protective immune response, which will render the horse susceptible to infection after cessation of therapy. So if the guttural pouch infection is left untreated, then it will result in persistent guttural pouch empyema. So we can also use drugs like tetracycline, which is given at the dose rate of 10 mg per kg body weight, and below I have mentioned few brand names of tetracycline. The pus materials from nose, eye, etc. should be carefully mopped with antiseptic solution. So now let us come to prevention. The post-exposure immunity of this disease is prolonged and is associated with local production of antibody. So the animal that has come in contact with the infected ones should be passively immunized by immune serum subcutaneously at the dose of 200 to 300 ml for a few days consecutively. Freeze-dried strangle vaccine is also available, and the doses are as follows: foal up to 6 months, 4 injections at 10 to 14 days interval consisting of 1 ml, 2 ml, 4 ml and 8 ml through subcutaneous or intramuscular route. Foal 6 months to 2 years of age, 4 ml, 8 ml, 16 ml subcutaneously or intramuscularly at 10 to 14 days interval, and foal 2 years of age and more, 2 ml and 20 ml subcutaneously or intramuscularly at 1 month interval. So control. The affected horses should be kept separately and also should be cared by separate caretakers wearing protective clothing. The rectal temperatures of all the horses that are exposed to strangles should be obtained twice daily, and those developing fever should be isolated. We should decontaminate the instruments by chlorhexidine gluconate or glutaraldehyde. Flies can also transmit the infection mechanically, therefore control of fly population is also necessary. Farriers, trainers and veterinarians should wear protective clothing or change clothes before traveling to the next equine facility. So the new horses, before introducing them to the herd, should be examined for evidence of disease or shedding by nasopharyngeal culture, and they should be quarantined for 14 to 21 days. So during that period, 2 negative nasal swab cultures should be obtained at quarantine. So most horses continue to shed Streptococcus equi for almost 1 month after recovery. We must obtain 3 negative nasopharyngeal swabs at an interval of 4 to 7 days before releasing them from quarantine, and the minimal isolation period should be 1 month. The bacterial shedding can be prolonged and it can be as long as 18-month old, and it is seen in few number of horses. Guttural pouch empyema is a source of infection in most prolonged carrier states, and we can identify these carriers by taking swab cultures. So these are the references from where I have obtained all the information about this disease. I have attached the links here. I hope you liked my presentation. Thank you very much.